welcome everybody. And this is indeed an honor to have two great events in the same week by the same speaker. And this is the second of the talks we're going to be having. And this is Statin Week. So we're going to learn all about statins. So part one we had last Tuesday, and Dr. Alnoor Abdullah, cardiologist, Vancouver, who's spoken to us before in the past and who has volunteered to come and to share his knowledge without pay with his colleagues, and we're very grateful for him for that. So he gave an amazing lecture on Tuesday, one of the best organized and inclusive and I'm not going to say simple to understand, but you could follow it, and he did it in such a way that I was myself learning stuff that I thought I knew everything, but I changed my mind very quickly. The other thing that I'm going to pass on to you for today, which I did, and I will pass on to the group, is to use your screenshot mechanism on your computer. If you don't know how to do a screenshot, get someone to teach you, because some of the what's the word? So some of the slides have all these summaries on them, and you know, if you can just screenshot that thing and put it in your computer's storage thing, you're under CME best things that happen kind of category. You can learn a lot of stuff, and then you can print them and put them in your own office in a folder somewhere when you're stumped as to how to organize things. Excellent thing to do, and I got quite a few last time, and I will share them with the group later on. So, Dr. Abdullah, I'm going to shut myself down very quickly, and I'm going to ask you to take over, and I'm going to shut off my video on that. Please, all questions go into the chat room. I will allow you all to ask verbal questions later. And if there's anybody who hasn't renamed themselves and you've got things on there like iPad Joe or something, please do that now. I'll try and do it myself after. And we're back now to statins, beyond statins and LDL. Why go there? Dr. Alnoor Abdullah, please.
Thank you very much, Michael. I must say it was an enjoyable session for me as well on Tuesday, and I enjoyed giving the presentation. And we dealt with the LDL story, and then we dealt with the statin situation and what are the limitations of statins. And now we are at part two of where do we go beyond statins. So, you know, you saw the disclosure slide last time. The only 2 points I want to re-emphasize is if I say the word he or she or that, I actually just is gender interchangeable. And the second thing I say, you know, in my office, so I'm with a patient, or I put this on my wall in my office, I am talking about when I was actually clinically practicing, and I'm now not practicing, and therefore I don't take referrals. I just primarily do cardiac education and medical navigation. All right, so back to our famous slide. You've seen it a few times. This is a recap of the LDL story. And what we know is that when you measure total cholesterol, it's all the cholesterol that is in all the lipoprotein particles. And the cholesterol that is attached to the ApoB particle, the lipoprotein particles that have ApoB protein on them, are the atherogenic particles. And all of them contain cholesterol. The LDL contains a lot more cholesterol and is a lot more concentrated with cholesterol, and it can have very small, dense particles. And with the help of ApoB, this goes into the subendothelial space and causes atherosclerosis. Now, all the particles contain cholesterol, and so do the lipoprotein particles that are attached to ApoA, and that cholesterol is being carried in that lipoprotein shroud or capsule and is unable to enter the subendothelial space and therefore is non-atherogenic. So what we really want to know is all the cholesterol that is not HDL cholesterol. So we take the total cholesterol, subtract the non-HDL, the HDL cholesterol, and come up with a non-HDL cholesterol. And as expected, it is a far better predictor of risk and a far better predictor of how well you're doing with therapy than just LDL measurements or LDL calculation. And LDL has been used as a poster child for all these atherogenic particles because it has the most concentration of cholesterol, and in large long-term clinical trials, it essentially mirrors the non-HDL cholesterol. But for the individual patient in your office, the important issue is the non-HDL cholesterol and not just the calculated cholesterol LDL that is reported to you, because that leads you to underestimate the risk. And all these particles contain triglyceride as well, which we will be dealing with. So the analogy I want to leave you with is that ApoB is a drug lord. He's a drug pin. He's one of those guys who's controlling a huge amount of drug trade. He's the one who controls and strategizes everything, his relationships with the border people, and he's the one who gets the drugs into the country, into the subendothelial space. And he is a polygamous guy, and he has multiple wives, and all his wives are involved in the drug trade, and therefore they are all doing bad things. And but some are not as bad as others, like the small dense LDL. So if you were to be making a movie of this drug pin and his drug trade and everything, then this young, vivacious, amazing-looking girl would be the lead star in that movie, but she's the most vicious, and she actually handles the killer gang in the drug trade. All right? So remember that analogy. All right. So what do we do in clinical medicine? You get many numbers to remember what the targets are for high risk, really high risk, and what ApoB targets and non-HDL targets. And it's difficult to remember them on a Thursday afternoon. You have lots of patients and you are running 40 minutes late. You're not going to pull out something to reference that. So I explained to you that at birth we have LDL of 1, and therefore we should try and get the LDL to as close to 1 as possible, but it is an inaccurate estimation. So the more accurate one is the non-HDL cholesterol, and the number to remember is 2, to try and get it as close to 2 as possible. And if you are going to measure ApoB, the drug king himself, then again, he's the 1. So you try and get it to 1 as much as you can. All right. We also learned about statins, that the use of statins appropriately brings about excellent improvement in cardiovascular outcomes. For each millimole reduction of LDL cholesterol, you get about a 21-22% reduction in all vascular events. Doesn't matter where you start from. If your baseline LDL is 3 and you get it to 2, you get a 20% or 22% improvement. If your baseline LDL is 2 and you get it to 1, you still get another 20-22% improvement from that baseline number. The problem with statins is that they have limitations. They deal with intolerance, that deals with intolerance to statins, and that is the true drug-related side effects that the patients feel. And you shouldn't discount those because they do occur. And then there's the nocebo effect side effects, which occur because the things have been drummed into the patient's mind from the media or the list that the pharmacist gives them, or the dietitian or the nurse or you yourself, and they actually feel that they are getting these side effects, and it is primarily due to this power of suggestion, which is called the nocebo effect. And or these issues of statin intolerance are related to the fear. The patient is just reluctant to start taking the statin, or even when you give the prescription, reluctant to fill the prescription, or if they fill the prescription, reluctant to take the meds because of fear that potentially something may happen to them. And I'm telling you, in our career, in our lifetime, we are not going to be able to overcome this with statins completely. So we will have to live with that and learn to handle that. The other limitation of statins was the variability. Statins are a patient-specific drug. They are not a disease-specific drug. So a disease-specific drug is the one you give the drug and it just takes care of that disease. A patient-specific drug is if you give the same drug at the same dose to patient A versus patient B, they can get completely different beneficial effects and completely different side effects. Then there is the problem of adherence of taking a medication on a daily basis, and there's polypharmacy in these cardiac patients. But the most important limitation of statins is we have been unable to get LDL cholesterol levels low enough in a lot of the very high-risk patients, and therefore we are not getting the full benefit of decreasing the cardiovascular risk. So any new treatments that we are going to bring in have to overcome these limitations of statins. Otherwise, they are really just another one on the block. All right, so you're going to see this slide a few times tonight. The vast majority of cholesterol is produced in the liver, but some in the intestine, the adrenals, the skin. And there is absorption of cholesterol in the gut. And this absorption of cholesterol in the gut is from two sources: the food you eat, and a lot of the saturated fat, trans fats, and the carbohydrates, the starches, are the ones that are absorbed, which actually lead to liver cholesterol production. And the actual cholesterol intake, like an egg yolk, plays a minuscule role in your blood cholesterol level. So eating an egg on a daily basis is not going to impact your blood cholesterol level to any significant degree. But eating a lot of starch or saturated fat or processed foods with trans fats is going to hugely impact your blood cholesterol level. And there is an equilibrium in the body that if the liver feels it doesn't have enough cholesterol within its cells, this homeostatic situation is such that there is an increased absorption of these substances from the gut so that the cholesterol level goes back up. So there is a homeostasis between production and absorption. If you produce too much, you absorb less. If you cut down the production, you increase the absorption. So patients who are on lipid-lowering therapy like statins actually end up efficiently absorbing the bad stuff. So they are even more likely to get into trouble with bad diets, and they should be even more careful because the absorption mechanism has been enhanced. All right, down here, if we want to bring down the blood cholesterol level, we can either decrease the production of cholesterol or we can increase its clearance. And statins decrease the production of cholesterol. I explained that to you. They drop the cholesterol in the liver cell. The liver cell then assumes that it has low amount of cholesterol. It upregulates the receptors, and there's more receptors on the surface, LDL receptors, and the LDL receptors go ahead and suck the cholesterol out of the blood, and so your blood cholesterol level goes down. So it all happens through the LDL receptor, and we know the limitations. All right, so let's deal with the first cholesterol-lowering drug aside from statin that we have available. It comes only in a single strength, so it's the same dose for everybody. And so there is no dose finding. And it's available, and you can just write a prescription, and the cost is not prohibitive. And I believe the generic form is available as well. So what does it do? It decreases the absorption of cholesterol and the various fats in the upper intestine, in the jejunum and the duodenum. So by decreasing the absorption, it's decreasing the absorption of these bad substances that come from diet, but a large amount of the bad cholesterol and fats that are in the upper intestine come from the bile, and there is the enterohepatic circulation. And what ezetimibe does is it blocks that absorption, whether the bad substances came in your diet or whether they came in the bile, and it blocks the absorption of cholesterol through the enterohepatic circulation. And therefore, the cholesterol level drops in the liver. It upregulates the LDL receptors, and they suck out the cholesterol from the blood, and your blood cholesterol level goes down. All right, so what else do we need to know about ezetimibe? We need to know that if you are taking a statin and you double the dose, you only get a little bit, 6% more benefit. And if you double the dose further, you get only another 5% benefit. And if you double the dose even more, take the atorvastatin to 80, you get only another 5% benefit. But if you take the lowest dose of statin, the starting dose, 10 milligrams, and you give 10 milligrams of ezetimibe with it, now you're doing a dual blockade. You get about the same amount of cholesterol reduction as a very large dose of statin. So it allows you to use a lower dose of statin, and that is psychologically good for the patients to follow the drug, taking the drug, and also decreases the side effects, which are a lot of the side effects are dose related. So it also allows you, because of the combination, for any level of LDL risk, it allows you to attain the targets much better. So you reach the effective levels of lowering LDL cholesterol with the addition of ezetimibe to statin. So is there outcome data? We did the large outcome study, which is called the Improve It study, and it clearly showed that statins alone versus statins with ezetimibe, the ones that took ezetimibe as well, had a 20% reduction in events, and that was statistically significant. So we have outcome data, and all the bad things that happen with regards to coronary heart disease decreased with the combination with ezetimibe. And strokes decreased as well. And the side effect profile was not changed at all between the SIMWA group, the statin group, or the statin plus ezetimibe group. The patients did not really notice that they were taking ezetimibe or a placebo with the statin. So that's very helpful. So back to our main slide, ezetimibe drops the absorption, and it helps you decrease the adverse effects by allowing you to use lower dose of statin. And it has a consistent response at one dose for everybody and just does its job equally. And it improves your adherence, I think, if you are able to tell patients to take lower dose of statin with it, or that they get less myalgia with it because you've dropped the dose. I think you get better adherence. And it definitely enhances the LDL reduction and improves the outcome in well-run outcome randomized studies. So let's move to PCSK9. Those are available now, and they are monoclonal antibodies. They go in and neutralize PCSK9. So we have to know what PCSK9 is. Why do we have to go neutralize it or inhibit it? It comes in alirocumab or evolocumab. Any drug that ends with a mab in oncology or any field is a monoclonal antibody. And if it has a U in front of it, it's a totally humanized, developed monoclonal antibody. So you have Praluent or Repatha. It's given as a sub-Q injection once every 2 weeks or once every 4 weeks if you take a higher dose. The cost is the big issue. You need special authorization, and it's not hard to do. And almost every patient that needs it is able to get it. All right, so it goes to inhibit the PCSK9, which upregulates the LDL receptor. So again, these drugs work through the LDL receptor. So what happens? These little particles here are LDL cholesterol. These Y-shaped things are the LDL receptors. And these yellow things are PCSK9 enzyme, which is also produced in the liver. So the receptor picks up the LDL So in order to drop the blood level of cholesterol, takes it inside the cell and it goes to the endosomes. And in the endosomes, it is cleaved, the cholesterol is excreted in the bile, the receptor goes back to the surface and keeps doing its job. So you don't deplete the receptors on the surface. Unfortunately, when you have PCSK9, it also binds to this receptor when the LDL binds to this receptor. So they now go not to the endosome, but they go to the lysosome because this three-part complex. What happens in the lysosome is everything is just destroyed and metabolized. So the cholesterol is all destroyed, the receptor is also destroyed, and so it does not recycle back to the surface, and therefore you cannot clear more and more LDL out of the blood. So this is how PCSK9 is bad. So LDL is bad, PCSK9 is bad. So if you inhibit the PCSK9, you're going to do very well. So how did we learn this? We learned this from Mother Nature. We know that there is this dominant, autosomal dominant familial hypercholesterolemia. And if you have two of those mutants, then you have homozygous and you have extremely high cholesterol levels and you get heart attacks under the age of 10, but often in teenage years and in your 20s. And we learned that you have these two large dominant mutations, either of the LDL receptor or of the ApoB. What happened is in 2003, we found this other very severe mutation of the PCSK9 gene, and it was an autosomal dominant. And these people had essentially all the manifestations and findings and outcomes of those patients who had familial hypercholesterolemia. So now familial hypercholesterolemia can occur due to mutations in 3 genes: receptor gene, ApoB gene, or the PCSK9 gene. So we went along and we sort of said, well, if there is this enhancement of PCSK9, nature must have been good and will teach us there has to be some mutations where there is loss of function of the PCSK9 gene. Well, lo and behold, there are populations where the PCSK9 gene has these minor mutations, and these people have lower levels of LDL cholesterol from birth. And they have essentially no coronary heart disease. The reduction is close to 80–90% in these people. And then we carried this further in the ERIC study, and we found that this was really more prominent in African Americans, where it dropped the LDL and it essentially eliminated them from having coronary heart disease, even though a large number of them had hypertension or smoking, had diabetes. And in the European Americans, these mutations drop the LDL not as much, and you get significant reduction in coronary events over their lifetime. So we said, now we know this. So we've got to either create that mutation or we've got to inhibit the PCSK9 because that's the culprit. So we developed these antibodies, and these antibodies go and attach to the PCSK9 molecule and does not allow the PCSK9 to attach to the LDL receptor. So the LDL receptors now can do their job to clear the cholesterol out of the blood and be recycled back onto the surface. So in summary, PCSK9 levels are markedly dropped with PCSK9 inhibitors. There is a remarkable improvement in LDL receptor function and numbers, and LDL cholesterol drops dramatically. And if you look at this, with one subcutaneous injection, you get this dramatic reduction in PCSK9, and you repeat the injection every 2 weeks, which is the blue line. You get dramatic reduction in PCSK9, and the corresponding LDL just drops right down over 60–80%, and it continues all along the way, as long as you take the injection every 2 weeks or every 4 weeks. So it is highly effective, consistent, potent, and durable effect. it not only drops LDL cholesterol, it drops the kingpin itself. The drug lord himself drops the ApoB, and also drops non-HDL cholesterol, which is all the culprits, all the wives. And it also drops Lp(a). We'll talk about it later in the evening. Okay, so within 7 years from the discovery of the gene, we were already doing human trials. And in 10 years, we published the article demonstrating that PCSK9 inhibitors lower LDL cholesterol. And not only do they lower LDL cholesterol, they also decrease outcomes. So they lower they block the PCSK9, they allow the receptors to do their job, LDL cholesterol goes down, so does ApoB and all the other bad atherogenic lipoproteins, and people have less heart attacks, less strokes, and less premature death. So we completed the whole cycle with alirocumab, and we went ahead and completed the cycle with evolocumab as well in the Fourier trials, and demonstrated improvement in all the bad outcomes in these patients in the long outcome trials. And the only thing in the Odyssey program, which used alirocumab, there was obviously local injection site little reactions that people get, but these were almost all mild. And some of the patients complained of myalgias in the alirocumab arm. In the Odyssey program, which used evolocumab, which is Repatha, there was no correlation with neurocognitive disorders or with myalgia. So we are not sure whether these PCSK9 inhibitors cause neurocognitive disorders, and most of the studies have now shown that they don't. And most of the studies have shown that there is no increased myalgia with the PCSK9 inhibitors. So they work extremely well alone, and they work really well in combination with the statins. So back to our main diagram, they improve LDL receptor function and numbers by blocking PCSK9. You get much less adverse effects, and it's highly consistent results, which are very durable. And the dose works on everybody that we give it to. Is improved adherence, therefore, because you just have to take this little subcutaneous injection every 2 weeks, every 4 weeks. And actually, it is so easy to take. You have these injectors like a ballpoint pen, and you inject yourself in the tummy or in the arm or in the thigh. And it's a 28 gauge needle, and you don't even feel the needle going into the skin, and the drug is delivered. I can say that because I take it. So I know that for a fact. All right. So now we know that back to that slide a little bit. So a lot of the limitations of statins are overcome with PCSK9 inhibitors. And more importantly, we can get more and more patients down to that really low LDL levels that we want them to go down to, including dropping ApoB and Lp(a). So we say to ourselves, well, we've learned from nature that you can go mess around with the gene, and therefore you will produce less PCSK9. So instead of just inhibiting the PCSK9, why don't we go ahead and decrease its production? So how do we do that? So we developed this little RNA molecule, synthesized a string of RNA, and we call it siRNA because it is not messenger RNA. It's small interfering RNA. Its job is to go interfere with any other RNA in the cell. So it runs interference, all right? It's given as a sub-Q injection, 1 dose for everybody, and you give it the first day, just booster it in 3 months, and from there on, the patient has to just take it once every 6 months, period, twice a year. End of story. Cholesterol is gone. All right. So how does it work? It decreases the production, and therefore it doesn't produce PCSK9, and therefore LDL receptors work very well, and the name of the drug is inclisiran. And as I mentioned here, it's not approved yet in Canada or the US. It should be approved later this year or next year. So this drug is just around the corner and we will be using it. All right, so inclisiran. Remember I told you that PCSK9 is bad and it blocks the receptor and it destroys the receptor in the cell, and therefore you can't clear the cholesterol. So now we are going to try and prevent the production of PCSK9. And we inject this siRNA strand of genetic material that is synthesized, and it's attached to this conjugate protein, and I'll tell you about that in a second. It goes in there and it runs interference. The nucleus from the gene makes a messenger RNA to go into the ribosome to make PCSK9. This string of siRNA runs interference with this messenger RNA, and it cannot translate the information in the ribosome to make PCSK9. So again, it's all about interfering with the PCSK9 or decreasing its production. So why this blue dot? This blue dot is a molecule that's attached, conjugated to this string of siRNA. And what is the benefit? The benefit of this conjugated part of the complex is that it only gets into the hepatic cell if there is the SPAR receptor. And this receptor is only found in liver cells. So this drug is only going to go into hepatocytes. It's not going to go into muscles, in brain, or anywhere else. So it is hepatic specific. And the other part of this complex is that inside the cell, the process of messing up with the messenger RNA is attachment to a complex called the RISC complex, RISC. And when it is attached to that RISC complex, it just sits there and sits there and sits there and keeps interfering with the messenger RNA. Doesn't matter how much messenger RNA the nucleus puts out. All right. So it lasts for a long, long time. One injection, 6 months, cholesterol is down. There we go. One injection, LDL is down. It knocks out the PCSK9 because it's not produced. And it's long-term durability and consistent effect. And when it comes to the side effect, 2 large trials, the Orion 10 and the Orion 11 trials, looked at people who took the placebo injection versus those who took the inclisiran injection, and they were all on statins and all had their LDL cholesterol as low as possible that with the maximally tolerated statins. And the only side effect of consequence that was seen more in the inclisiran group were the local skin effects at the injection site. No other side effects were different between the inclisiran group and the placebo group. So it's a small interfering RNA. It's injected in the form of a complex, so it only goes into the liver and it sits there for a very long time and it keeps messing up the messenger RNA and stops producing PCSK9. So the receptors now are increased and upregulated, and they clear more and more cholesterol out of your blood. And the long-term safety and does it really improve outcomes, we do not know. The trial is ongoing. It is supposed to complete in 2024, but I believe it will be completed long before then because of extremely high benefit, and the Data and Safety Monitoring Committee will probably stop the trial early. That's my estimation of this issue. But presently, it is not available. It's going to get available later this year or next year before the outcome trials actually come out, and all new drugs now actually come out and are approved before the outcome trials are finished. And if you want to know why, you can ask me that in the discussion section. All right, so back to our big diagram. It's a potent drug. It's amazing durability and action. It has no increased side effects over and above what other drugs the patient is taking. It is superb in terms of adherence because they only have to take 2 shots a year. And it is highly effective even in patients who have not reached target at maximally tolerated levels of statin. All right. So that's inclisiran is just around the corner. There is another drug which is available in the US, but not yet in Canada. It's around the corner. In the US, its trade name is Nexatol. It comes only in one dose, 180 milligram, same dose for everybody. And it also comes in combination with ezetimibe. But it's one tablet taken daily, like the statins. And so, it does its job by decreasing the cholesterol in the cell, upregulating the LDL receptors. How does it do that? How does it decrease the cholesterol in the liver cell? It is given, bempedoic acid is given as a prodrug. In the liver, it gets conjugated to the active drug, and it blocks the cholesterol production pathway way up at the acetyl enzyme level, well before the HMG coenzyme A reductase level where the statins work. So essentially, it's a statin given as a prodrug and works at the earlier phase of cholesterol production than statins do. Well, why do we need it? We need it because it does its job in the liver, because it has to be conjugated, made to an active drug, and that conjugation process only occurs in the liver. And I told you that cholesterol is made in the muscle and intestine and skin and other places. And statins go there and they do their metabolic activity in the muscles. Bempedoic acid cannot do that in the muscle because it doesn't have the enzyme there to activate it into the active drug. So it does nothing in the muscles. And lo and behold, wouldn't it be amazing that it is a statin without any muscle side effects? And this is what the hope is for bempedoic acid. So in patients with persistent hypercholesterolemia, despite maximally tolerated doses of statin, it improves the cholesterol even further. In hypercholesterolemic patients who cannot take statins, it is an excellent substitute, does the job just like statins. In one of the long outcome trials, there were no safety concerns by adding bempedoic acid in patients who were on statins or who could not take statins, with or without ezetimibe. So we have some data which is very encouraging. The big outcome trial is underway, and we should get the results by 2022 and probably earlier, and we will know whether it actually improves outcomes like the statins do, and hopefully without any of the muscle side effects, and therefore not carrying any of the baggage that statins carry with the bad press, the internet, and the nocebo effect and all those other problems that we will never overcome. So back to our diagram, it works on the production side. There is no concerns as yet with regards to adverse effects, but we have to wait the long outcome trial. The response is definitely better because you get better reduction of cholesterol on top of statins or instead of statins. So you hopefully will get better adherence if you don't have muscle side effects, but we have to wait for the outcome studies, but it really does the job. Does it stop heart attacks, strokes, and premature death? We need to see that. All right, I'm going to tell you about this drug. And while I'm telling you about this drug, you're going to say in your own minds, why is he wasting his time talking to us about this drug? Because we're never going to use it. So this is evinacumab. It has a U, and it has a MAB. So it is a humanized monoclonal antibody. And it is an inhibitor of a substance called ANGPTL3. You better remember this. You're going to hear ANGPTL3 forever and ever in the coming years. And it is available in the trade name Efficacy, approved in the US. It's given as an IV infusion over 60 minutes and has to be repeated every 4 weeks. Because it works through ANGPTL3 inhibition, it has nothing to do with the LDL receptor and nothing to do with PCSK9. So therefore, it should work in patients who actually have mutations of PCSK9 or LDL receptor mutations, where genetically they have a problem there, but you can lower their cholesterol now working through completely different mechanism by inhibiting ANGPTL3. So what is ANGPTL3? I mean, I can show you a lot of complex diagrams, but in essence, it's just this. ANGPTL3 works at a very high level in that cholesterol lipoprotein cascade, and it works on the triglyceride-rich particles where lipoprotein lipase causes lipolysis and basically breaks down the lipids. So lipoprotein lipase does a good job to break down lipids. Unfortunately, ANGPTL3 is a brake. It puts a brake on how active lipoprotein lipase can be. So it's an inhibitor of lipoprotein lipase. So we come along, develop an antibody to ANGPTL3 with evinacumab. We block the ANGPTL3, and therefore we inhibit the inhibitor, and therefore the brake on lipoprotein lipase is released, and it does more of its job and increases the lipolysis high up in the upstream of the cascade of lipoproteins. So because it works way upstream at the triglyceride-rich particles, it will have an effect on all the lipoprotein particles. So it works up here at a very high level. So everything down from there is going to be impacted. And there it goes. It lowers triglyceride, it lowers total cholesterol, it lowers LDL, it lowers ApoB, it lowers HDL. It just lowers everything because it's working high up there, upstream, and clearing the lipids with the lipolysis at that level. And so if you take patients with homozygous familial hypercholesterolemia, they have no LDL receptors, or they have PCSK9 gene that is dominant, or they have an ApoB gene that is dominant. So they cannot clear cholesterol from their blood. And you give them evinacumab, and it knocks out their PCSK9, knocks out their cholesterol in a durable and long-term fashion. And you have to keep repeating the drug every 4 weeks intravenously. So we don't know about the long-term side effects. We don't know about the response because it's only really been tried in those autosomal dominant patients with hyperlipidemia. The adherence is going to be a problem because you have to give it intravenously every 4 weeks. But the effectiveness is amazing. It is effective in people in whom all other drugs that we have so far that I've talked to you about now are highly ineffective. And evinacumab still goes and knocks down all the lipoproteins. So why do you and me, clinical doctors, need to know about it? There are at least 7 or 8 ANGPTL3 inhibitors in development. And they are going to be different. They are going to be probably able to be given subcutaneously, probably able to be given orally, and you will have to learn to use those drugs. And you are already a master of this now, because I've told you that you just have to block the ANGPTL3, and we are in business. Okay, so now we know that if you mess up with the gene, either with loss of function of the gene or autosomal dominant gene, you get the benefit or the additional risk of cholesterol production. So we say, well, instead of working in the cytoplasm and the mitochondria with the statins and bempedoic acid, instead of working in the ribosomes with the PCSK9 inhibitors or the inclisiran, which is drops the production of PCSK9 and messes up the messenger RNA. Let's go right down into the nucleus and let's mess up the gene. Let's actually mess up the gene that is supposed to make PCSK9. Don't wait for the messenger RNA. And that's CRISPR gene editing gene silencing technology, completely and totally initially developed in Canada. And we are already using it clinically in patients with sickle cell anemia and curing sickle cell anemia with one-shot treatment. So what we are doing now with CRISPR gene editing is we're going ahead and messing up the gene that tells the cell to make PCSK9. We now make the gene silent. We basically edit the gene and make it silent, so it cannot pass on the message to make PCSK9. And if you think that this is Star Wars medicine, it's not. We know that from nature, that when you have these minor mutations in the gene, you actually get lower LDL and you get almost complete reduction of coronary events. So we found these families, and this started in Zimbabwe and South Africa in the antenatal clinics. These women used to go to the antenatal clinics, and there were people who wanted to do research on them. And so they measured everything they could measure on them. And some of the times they also measured the lipids. And they found these women, some of them, who had extremely low LDL cholesterol levels in the range of 0.4. And they were doing fine. They were conceiving. There was no issue with sex hormones. They were going to school. They were graduating from college. They were physically active, and they were doing fine. So it gave us the confidence to go ahead and start messing up with that gene. And so we said, even in people where that gene is completely absent, we have not seen very much bad effect. So this is the paper published in Nature in May of this year. And you know, on CNN, you get breaking news. Most of it's not breaking news. But this paper published in Nature, the highest impact journal in medicine or in science, is absolutely a game changer. And it is definitely breaking news. And we can now go up to non-human primates, and we can do this one-shot therapy and absolutely eliminate their PCSK9 levels in group 2, where it was done a little bit better, and bring down the LDL cholesterol levels. And that's it. For the rest of the life of that primate, the LDL levels are going to stay low. So we are now moving from non-human primates to human studies, and that will bring about CRISPR gene editing or silencing in hyperlipidemia, as it has already done in other diseases like sickle cell disease. So back to our diagram, if we do CRISPR gene editing, it will work on the clearance of cholesterol through the LDL receptor, because it will essentially stop producing PCSK9. All right, this paper was produced, it was written in January this year, and it talks about the most important advances in preventive cardiology during the past decade, and it lists those medications, and you can see they talk about statins, they talk about icosapent ethyl, so you will have to stay for the rest of the talk so that I can tell you about that. They talk about PCSK9 inhibitors, they talk about PCSK9 production blockers, and they talk about inflammation, which will be part 3 presentation if I'm allowed to give you part 3 in the fall sometime. All right. So let's move to the second part of the talk. We now know what we can use beyond statins. And now what about the other lipids besides the lipids that are non-HDL cholesterol lipids? So what about triglyceride and what about HDL? All right, now again a reminder, it is not about the residual lipid risk. It's about the residual cardiovascular risk for the whole patient. So if their blood pressures and smoking and other issues are not taken care of, there is residual risk, and you have to take care of that at the same time, in order to make the total patient have lower cardiovascular risk. But when it comes to residual lipid risk, excuse me, it's a situation where the LDL cholesterol stays above the high risk level. And now we know we have drugs, which I've already talked to you about, that can bring it down to less than 1.8 or even down to 1.2 or lower. So what is the other residual risk? The other residual risk is triglyceride and inflammation and thrombosis with antiplatelets and all that stuff we'll talk about someday. And LP little a, which we are going to talk about a little bit tonight, and some others that we don't know about. What is missing? There is not a word here about HDL. This was a presentation this year in April on the latest in lipid management from Harvard. Okay, so let's just look at this slide I made 10 years ago in 2011. I had all these atherogenic particles, and I had HDL-EPO-A written as anti-atherogenic. So let's look at the HDL story quickly, and we go back to the 1977 era, where a paper presented by Gordon, Gordon, Castelli, and Cannell are the three fathers who started the Framingham study, and who are the ones who taught us everything we know about cardiac risk factors. So they were very concerned and very vocal about this HDL-LDL interaction, and they published that in 1977. And so there was this big thought. And if you read the paper itself, there is a sentence in that paper that Gordon says, thus, efforts at raising HDL through combination therapy has the potential to improve upon the limited effect of monotherapy treatment of LDL. So what were they thinking? They were thinking that just monotherapy of bringing LDL down is probably not going to do much. It's going to have some effect, but really the best thing will be to raise HDL. Okay. And so come 1983, it's the same person, the same group. Cannell now writes the paper, and he says, that cardiovascular risk decreases every time you decrease HDL is increased. So if you increase the HDL, the risk drops, and it keeps going. But now he's beginning to worry, and he says, but the word association is used purposefully and does not imply causality. All right? So now the fathers themselves, who were so high on HDL, are beginning to say, is it really important in the process of atherogenesis? So we used to consider this slide the gold standard. Nobody could give a lipid talk without this slide. It talked about all the atherogenic lipids, and they went from the liver, and they went to the artery, and ApoB had the job of taking them to the artery. So it was a directional flow. And then ApoA came around and picked up the cholesterol, and in a directional manner took it to the liver. I learned in first year anatomy that blood circulates all over the body. And if something is in the blood, you cannot tell that thing to only go here or there unless you have a mechanism to allow it to enter a particular organ or not enter it. All right. So this directional approach began to fall apart with HDL, because most of the HDL is really taken up in the liver with the HDL receptors. So what else did we learn about HDL? We learned that HDL is not HDL. It's just a whole bunch of lipoprotein particles, except that they are attached to the apoproteins, which are mostly A, but not necessarily all A, but they are not B. They are not connected to the drug load. And therefore, they are not wives of the drug lord who are also doing bad things. All right? So we began to learn that this was an amorphous group of lipoproteins. And look at it here. HDL3 has all these apoproteins. HDL2 has all these apoproteins. And if Arun was here today, like he was on Tuesday, you can understand why I am not a big fan of measuring ApoA1. Because
Actually, he is here and he's got his eye on you, so be careful.
okay, Arun, this whole part of HDL was not needed tonight because we cannot improve outcomes with HDL. It's all because of your question on Tuesday. So enjoy it. All right, so here's the HDL particle. It's markedly heterogeneous and it's got all kinds of apoproteins attached to it. The only important thing is it doesn't have ApoB. And because it's not ever attached to ApoB, it cannot enter the subendothelial space and therefore does not cause harm. So here's our slide back again. And as I explained to you, ApoB is like a drug lord who makes sure the drugs get into the country, and his wives are all involved. He's polygamous, so he's a bad guy. He has all these wives, and they're all involved in the trade. And some of the wives that are vivacious and young, who are actually vicious killers, are the ones that cause most of the harm, the LDL. And if you were going to make a movie, she would be the leading person in actor in the movie. All right. So what's the HDL analogy? HDL analogy is Woodstock. Those of you who remember Woodstock was a festival of love and peace. A lot of young people got together for a few days and smoked weed and listened to all kinds of music. Now, all those people had a couple of things in common. Was that they were not causing trouble. They were not criminals. They were not drug lords. They were not wives of drug lords. They were an amorphous group of young people who were not just polygamous. They just kept partnering with anybody and everybody they wanted to. There was no actual partner that there was, except they never partnered with ApoB. So it's, and then what happened at Woodstock? There were all these bands and musicians who played music, and we remember some of them, but we all remember one of those groups, Simon and Garfunkel. And so we attribute the songs of Simon and Garfunkel to Woodstock, and they became the poster child for Woodstock music, and that is the same as ApoA1. But it is not all the people who were there, the amorphous group of young people who were partnering with whoever they wished, whenever they wished, and they were not just polygamous. There was just no rules. All right, so that's HDL. Now in the next minute for you, Arun, I'm going to totally explain to you the metabolism of HDL and all these multiple particles. So slide, 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 slide. And the knowledge gained about HDL over the years into the 2000s. What am I actually telling you? We do not know about this amorphous group of young people who actually had congregated at Woodstock. But what they actually do and where they come from and where they went and what is going on, we do not know. At the present time, we are accumulating more and more and more information about HDL and literally confusing ourselves. And for the practicing clinical physician, none of this is necessary. And the only reason I showed it tonight, Arun, was because you were on and your question last time. All right, so now let's go back to this diagram that Gordon, Castelli, and Cannell were so pushing. And now they come here and they change the heading. The same data from 1948 to 1970, the same slide, they change the heading. They say, now let's go for the quest of looking for HDL raising drugs. So they're still on this kick of raising HDL. So let's go find those drugs that truly raise HDL, and then we can decrease cardiovascular events. So all these purple spots are possible targets and chemicals or drugs or substances that can actually impact to increase your HDL cholesterol. And none of them have been shown to decrease your cardiovascular outcomes. So let's look at two drugs that we know about, niacin and the CETP inhibitors. So niacin does all these things. For the practicing clinician, it's not important. For the practicing clinician, what's important, that niacin drops LDL, lipoprotein A, Lp(a), triglyceride, and it raises HDL. So the people were focusing niacin on its HDL raising property. So the big coronary drug project was undertaken, placebo versus niacin, and it took 15 years to show a slight benefit in mortality with the use of niacin. And they wanted to attribute this to HDL raising. And in the group that were extremely high risk post-MI group, yes, there was a benefit in mortality, but it took 15 years for it to show up in a significant manner. So is it the raising of HDL that niacin did, or is it the lowering of HDL, lowering of LDL and other atherogenic proteins is what brought about that benefit? So if we look at statins and niacin in combination, bad cholesterol is dropped, triglycerides are dropped, HDL goes up. So that combination is very, very good in terms of what it does to the lipids. Well, here is the HPS2 THRIVE trial, a very large trial in which all the patients were receiving statin and their LDL levels were normal and therefore didn't need the statins, or if they were taking statins, their LDL levels were fairly low, below 2. And then the other group, they let them take those statins or whatever other drugs they were taking, and they added this long-acting, non-flushing niacin, and you can see that absolutely no benefit over 4 or 5 years of follow-up. No benefit of niacin, which raised the HDL, but it lowered the LDL, but the statins had already done that. So once you lower HDL with statins, niacin is no longer beneficial, even though it raises HDL. Well, we wanted another study, aim high. Same thing, statins, low LDL, other group, statins, low LDL, but also taking niacin. Absolutely no benefit at all. But they raised their HDL. So we said, well, maybe we didn't raise the HDL enough, and we are smart, and we know that we have to actually go inhibit the CETP enzyme. So if we block the CETP enzyme, we are going to raise the HDL properly. And this time we are going to specifically raise the HDL. Okay, so we gave this CETP drug, inhibiting drug, torcetrapib, and in the clinically used dose, it raised HDL dramatically. And all the PIBs, dalcetrapib, torcetrapib, whichever, they all raised HDL, and some of them raised HDL dramatically. Well, when we run the trial, in the DAL outcomes trial, zero benefit compared to patients who were taking other lipid-lowering therapy. And in this group, they were taking the same other lipid-lowering therapy and torcetrapib. All right? All right, so this was dalcetrapib in the DAL outcomes trial. So then we said, well, we have to use torcetrapib because it raises HDL even more. And lo and behold, what happened in that trial? Well, you look like that there was very minuscule difference in mortality and a very minuscule difference in cardiovascular event rate. But when you looked at the high-risk group, people who were at risk of really having events or dying, the group that got the CTAP inhibitor actually had more events and actually had more mortality. So this person, John LaMantina, who at that time was the president of Pfizer and head of all the research and development of over 1,300 scientists all over Europe, wrote a book on that issue. And part of it, there was an article in Forbes in 2017. And he said about that evening, on the evening of Friday, I added Friday, December 1st, 2006, the Data and Safety Monitoring Committee contacted Pfizer to say that it had noted that the combination with the PIB inhibitor and the atorvastatin actually ended up causing more mortality. And Pfizer then immediately discontinued the study within hours of hearing this news. So there went the PIBs, HDL raising drugs. That was on the 1st of December. The New York Times picked it up and reported it on the 5th of December. And the New England Journal took a year into November of 2007 to report the findings in these peer-reviewed journals. And the non-peer-reviewed open access journals also started to say there is no benefit in raising HDL. And he writes in his book, this ex-president from Pfizer, that $5 billion were spent by all these companies for the research and development of the CTAP inhibitors to raise HDL cholesterol. And that is the biggest failure in the history of pharmacology. All right, so back to this diagram. Now that they still show the diagram, but they've changed the heading. Coronary heart disease risk, HDL versus LDL predictor. And I was trying to tell you 2 days ago in the first part that HDL is a predictor. And so I changed this slide from 10 years ago to that HDL doesn't meet the triad. It predicts risk, but it is not integral to the atherosclerosis inside, and it does not, raising HDL does not drop the outcomes, and therefore it does not complete the Abdullah triangle on the three sides of the coin, and therefore it is not an outcome dropping drug. And I changed my slide this year to call HDL non-atherogenic. It's that amorphous group of people who love peace and love and smoke weed, but they are not criminals and they are not drug pushers or lords, and they don't cause harm. But if you send more and more people to Woodstock, or if you tell all the people in your city to start listening to Simon and Garfunkel, it's not going to decrease cardiovascular event rates. So that's just a surrogate. EPO1A is a surrogate. It's just listening to Simon and Garfunkel music. It's not going to decrease the event rates. All right, let's skip that, and just go quickly to the triglyceride story, because this is the important story. All right, so back to our slide. All these atherogenic particles contain triglyceride. These buoyant low-density ones contain more triglyceride. The small low-density particles ones contain less triglyceride and more cholesterol, and the HDL particles contain triglyceride as well. All right, and the Lp(a) contains triglyceride. Okay, so what is the analogy we are going to use? So triglyceride is this person, Mr. Triglyceride. He's a bad person, and he lives with his wife, who is extremely bad person. She is actually one of the mistresses of the drug pins and is involved in all this drug. And when he's with her, he participates and actually does bad things. But he is a neighbor, and his neighbor's wife is not only very beautiful, but she also is a very good person. And she's not going to is not going to allow him to do bad things. She's a good influence on him. So she's HDL, all right? So we know that when you lower LDL, triglyceride is still important. So it's an independent risk factor. Even in patients who have LDL lowered, the level of triglyceride portrays risk. And I'll speak to you about this atherogenic dyslipidemia. Atherogenic dyslipidemia has a large number of these small, dense LDL particles that I talked to you about in part 1. And so the particle number is more of ApoB, and that's a bigger risk and causes more events than the smaller particles, than the bigger particles. And look at triglyceride. The blue bars, as the triglyceride levels go up, you get more cardiovascular risk and events. And you look at the triglyceride, when it is adjusted for the level of HDL. So the more times this Mr. Triglyceride spends with this neighbor's wife, who is a good person, he's less likely to do bad things, versus when he's spending time with his wife, who is really an ApoB particle. All right. So when you correct for when he spends a lot of time with good HDL, it doesn't have as much risk. The risk seems to be modulated by the neighbor's good wife, who prevents the triglyceride from doing bad things. So HDL acts as a modulator for triglyceride. And look at this, where the triglyceride to HDL ratio is high. That means there is more triglyceride, very low HDL. He's not seeing the neighbor's wife very often, and he's doing all the bad things on the other side. You get tremendous risk. All right, so does lowering triglyceride help? Well, the Alkin's study showed that you can drop triglyceride and all-cause mortality drops, CVD mortality drops, and everything gets better, and coronary heart disease is down with gemcitabine. But look at this. Dropping triglyceride is not just good enough. Whether you drop it in the presence of high HDL, you get very less benefit, but you get benefit. But you get really more benefit if you drop it in the presence of low HDL. So HDL is the modulator. And so this triglyceride to HDL ratio is very important. And you can't leave this talk today until I tell you what number to look at in your offices. Okay, so triglyceride to HDL ratio is a new thing. It predicts mortality. It predicts who is going to get diabetes. Long before the hemoglobin A1C goes up, the triglyceride HDL ratio is going up. And this is the high ratio in black. You get more events. In the white bars are the low ratio, and you get less events. So you remember this from the part 1 talk. We want to only do 1-to-1 in our office, get the LDL as close to 1 as possible, non-HDL cholesterol as close to 2 as possible, ApoB at 1 or as close to 1 as possible. So really concentrate on the non-HDL, which is the full atherogenic risk, and the only number to remember there is 2 when it comes to ApoB particle atherogenic risk. So what about triglyceride to HDL ratio? If it's less than 0.9, it's very good. Very little risk is there with the triglyceride. If it's about 1.7, higher or close to 2, the risk begins to increase. If it's more than 2, it starts to increase. Now, are you going to remember these numbers in your office next Thursday when you are running 40 minutes late in your office? So you're going to remember this, 1-to-1 to 2. And the only number you got to remember is 2. You want to keep the HDL, non-HDL cholesterol as close to 2 as possible, and the triglyceride to HDL ratio as close to 2 as possible. If they are not there, treat those patients, and you will get a decrease in events. So what about fish oils? I'll go through that quickly. The Japanese jelly study was primarily done in women and only in Japan, and showed that giving EPA fish oil made a difference, improved outcomes, as long as there was no DHA in it. So no omega-6. If you give omega-3 only fish oil, there seems to be some benefit. And there was this big meta-analysis, and it looked at all the fish oil given omega-3 that we know about so far in all the trials, and there was no significant benefit. So we said we are going to develop a prodrug of EPA, which is icosapent ethyl, and it's going to get lipolyzed, and it will become EPA in the body, and you will get really high levels of EPA now, which will do all the good things at the capillary and the arterial level. And so this REDUCE-IT trial gave placebo, which was mineral oil, and they gave icosapent ethyl capsules, which is Vasipa, to this group. And lo and behold, even though their LDLs were controlled and they were taking statins, if their triglyceride was more than 2 or the ratio was more than 2, they got a benefit. They got less events. Well, lo and behold, came on the strength trial, and the strength trial did the same thing with a different EPA raising chemical, and it used corn oil as the control. And in that study, there was no benefit from raising the EPA in the blood with this pharmacological agent. And it was the same events as placebo corn oil. And if you superimpose the Vasipa or icosapent ethyl benefit, it fell on this same line. But the patients who took the mineral oil placebo had the higher event rates. So now we are into this era that placebo may not be placebo. It may be causing harm. And so this mineral oil could have increased the events, and really the icosapent ethyl did not do any benefit. So we are there today. Actually, in June, we are in this debate. And, and the thing is that the raising EPA pharmacologically is not without its problems. You get a lot more atrial fibrillation. So I say to Vasipa, not so fast. We are not going to start ordering it in everybody who has an elevated triglyceride when the LDL is well controlled. We're going to wait and see what happens. So now, do we have to worry about Lp(a)? This is only for that gentleman who wanted to come to the talk because of Lp(a). Here is Lp(a). What's the analogy? It's the illegitimate child of ApoB, the drug pin. But because he's the illegitimate child, he doesn't carry the same name or the surname, ApoB. He carries Lp(a), which is completely different from ApoA1 or whatever HDL is with. So it is highly atherogenic. All right? So he's the illegitimate child of the drug pin who is absolutely even more vicious than his father. All right. So I made this slide in 2011 and I've upgraded it this month. So Lp(a) is genetically determined, and darker skinned people have, have higher Lp(a) levels. So it has got a ethnic bias to it. It is completely genetically determined. Lifestyle does not matter. And you have to have levels really low. We used to do it in milligrams per deciliter, but now we've moved to nanograms per millimole. It is associated with significant premature coronary artery disease. It is highly atherogenic. It has other bad properties. It makes more thrombus. It prevents thrombus from being lysed. And so really it occurs in families who have strong family history of premature coronary artery disease. And even though niacin and CTAP decrease Lp(a), they have not shown any benefit. But we have PCSK9 inhibitors, inclisiran, we have evinacumab, all decrease Lp(a) significantly. And we are probably going to see promise with these drugs, not only for LDL reduction, but we are going to see promise for Lp(a) reduction. So who should we measure Lp(a) in? They say that we should measure it in people who have strong family history of premature coronary artery disease or have developed premature coronary artery disease or primary hypercholesterolemia, or reasonable to measure it in people who keep getting recurrent events, have poor LDL response. By the time you go through this list, which you will not remember next Thursday afternoon in your office, you will not know in whom to measure the Lp(a). I say always measure the Lp(a) when you order your first baseline lipid fasting lipid profile. And then again, when you are using treatment, which includes PCSK9 inhibitors or inclisiran, which you'll be doing very much in the near future. So that's what I would recommend, is to do it in everyone that you assess the full risk, particularly in patients who are South Asians or Black patients. It is a very important genetically determined level. And the patient says, "Doc, I'm very good. I have no risk factors. I do all the right things. Why am I getting this premature heart disease? My father had smoked, but I don't even smoke." Well, it is completely genetically determined. Lifestyle plays no impact on it. And we do not, the outcome trials are underway, and we do not know what the results will be. So putting it all together, today we have statins plus ezetimibe. We can use plus PCSK9 inhibitors, Repatha or Praluent, or we can just use PCSK9 inhibitors with ezetimibe, or we can use PCSK9 inhibitors by themselves, and that could be highly effective. We are in the process of getting a statin that may not have muscle side effects, works extremely effectively just like statins, and improves the LDL level even beyond taking statins, and works very well with ezetimibe. The big game changer will be inclisiran. You will need to take one subcutaneous injection every 6 months. It will knock out the LDL and the PCSK9, and we are just awaiting the outcome trials, and more than likely you're going to see dramatic decrease in outcome trials. You have to know about evinacumab, which works on ANGPTL3 inhibition, and you will be seeing compounds in that class that you will have to use in the future.